Hi everyone, in this video we're going to review the algorithm for cardiac arrest during pregnancy in hospital because they don't have a pre-hospital algorithm. But we are going to talk about some pre-hospital implications to this also, and we're starting right now. Now, as it pertains to cardiac arrest in pregnancy, the first thing is the basics, and that's all the same. We're going to ensure high quality CPR. We're going to ensure adequate airway management. We want to gain vascular access, and we're going to defibrillate as we normally would. So the basics still apply during pregnancy. Next, getting that OB team involved. In the hospital, you can simply call OB, have them come down, call a code, and then call OB. In pre-hospital, during your report to the ER, you gotta let them know, hey, I have an OB patient, alert OB, and they're gonna send a team down to meet you in the ER. I've had these arrests before, and the OB team is great during resuscitations, but they have to be there. They're the baby experts. So you wanna notify them quick, get them involved. Next, we have to consider the etiology of the arrest. Why did this pregnant patient arrest in the first place? We cover the etiology of maternal arrest in a separate video, but that needs to be discussed. From there, we're going to break down into basically two teams, the mommy team and the baby team, the maternal and the obstetrics. Okay, looking at maternal interventions. 1, airway. The pregnant airway right off the bat is a difficult airway. So your best shooter, your most experienced provider up there at the front to intubate that patient. That's number 1, airway management. 100% oxygen will be administered to mom. Chest compressions and basic BLS remains the same. We're doing quality chest compressions. Vascular access. We want to gain IV access above the diaphragm. So that's the ACs, but nothing, someone might be tempted in the ER to throw a femoral line in there. We want it above the diaphragm. And the thinking is that this gravid uterus is compressing down on the vena cava, and that can restrict blood flow back to the heart, so it can limit drug administration, arrival to the heart, fluids. So get an IV above the diaphragm. Same drug recommendations are recommended, so epinephrine is still appropriate to use. If the patient was on magnesium, which they often are in the case of, say, a hypertensive mom or preeclampsia, the recommendation is to stop the magnesium immediately. Consider calcium chloride administration to counteract that if they may be mag toxic, but we're going to stop the magnesium immediately. Now again, to get this down to 5 minutes means that OB has to be notified immediately. So when we call the code in a pregnant person, we're not just calling the code, we have to make it known that this is a pregnant person, and OB has to respond also, because in that 5 minutes, we need someone who's gonna be able to get that baby out of there toot sweet. Okay, on the obstetric or the baby side of the algorithm, you must perform left lateral uterine displacement. We have to get that baby off the inferior vena cava and the aorta. This must be done continuously. One person is dedicated to making sure that that baby is off that vena cava. Next, if we're in the hospital and we have fetal monitor wires inside mom, we want to remove the fetal monitoring wires, get those out of there. And our time frame really to deliver this baby now is 5 minutes. So from the time mom arrested, if she doesn't come back, we don't get her back right away and we achieve ROSC, we're going to do an emergency C-section within 5 minutes. That's the goal. Okay, so the big takeaways from this algorithm: mom gets 100% oxygen. She's going to be a difficult intubation. IV above the diaphragm. Continuous left lateral uterine displacement, or the chest compressions aren't going to be effective. And remember, from the time mom arrests, our goal is to get that baby out within 5 minutes. All of the other basic ACLS still applies. I'm Mark, thanks for watching. See you in the next video.